Welcome to Raaonline. Today's topic is immunological causes of recurrent pregnancy loss and its management. So what are the major causes of recurrent pregnancy loss? Chromosomal abnormalities, antiphospholipid antibody syndrome, and idiopathic cause is unknown or undetermined, or it can be immunological. So in today's lecture, we'll discuss about antiphospholipid antibody syndrome as well as the previously thought unknown or undiagnosed causes which are increasingly being recognized as being immunological. So when we say antiphospholipid antibody syndrome, we should not test for antiphospholipid antibodies. It is actually a misnomer. So what we should be actually testing to diagnose antiphospholipid antibody syndrome is anticardiolipin antibody IgG and IgM, beta-2 glycoprotein IgG and IgM, and lupus anticoagulant by activated partial thromboplastin type or diluted Russell Viper venom test. Now, antiphospholipid syndrome is of three varieties. It can be a thrombotic variety, it can be an inflammatory variety, or it can be a complement-mediated subvariant. Antiphospholipid antibody syndromes in obstetrical antiphospholipid antibody syndromes and in the vascular or the medical antiphospholipid antibody syndrome. Now, the medical antiphospholipid antibody syndrome, they are mostly thrombosis dominated and there is no inflammation. Whereas, obstetrical antiphospholipid antibody syndromes are inflammatory dominant antiphospholipid antibody syndromes, and their association with deep vein thrombosis and arterial thrombosis is rare. Coming to the non-thrombotic pathogenesis of obstetrical antiphospholipid antibody syndrome. So now we know that thrombosis is not the initial cause. So what causes an inflammatory APLA in obstetrical patient? So various levels can be there. So what are the levels, immunological levels at which the placental bed can be affected? So what we see here is the fetal tertiary stem villi with fetal blood vessels. And we see here the umbilical veins and the umbilical artery. And we see that the umbilical arteries and umbilical vein. And we see here these are the choriodecidual interface. So these are the chorionic stem villi. And this is the maternal side. We see the maternal vein and artery. And this is the decidual space. This is the maternal decidua or the inner lining of the uterine endometrium. And this is the decidual chorionic space. So, the fetal tertiary stem villi are located in this choriodecidual space. In this choriodecidual space, there is a crosstalk between the endometrium and the embryo. And what we see that trophoblastic, which is a fetal tissue, and the trophoblasts get bounded by antibodies. So these antibodies can cross the feto-maternal interface, and when they bind to the trophoblast, the antiphospholipid antibodies can promote trophoblastic apoptosis. They can inhibit trophoblastic proliferation and differentiation. So antiphospholipid antibodies can damage this interface. Now there is also an anti-angiogenic effect in APLA, in which not only the antibody mediated damage, it is also the prevention of formation of blood vessels. So APLA syndromes can have non-formation of spiral artery remodeling, and there can be affected angiogenesis in the maternal side. Now there can also be complement system activation in the APLA syndrome, and complement coagulation system activation and fibrin deposition and placental fibrosis can happen in these patients, and these antiphospholipid antibodies can bind to extravillous trophoblast and decidual cells, and they can activate the inflammatory pathways. So these are the four ways in which the antiphospholipid antibody syndrome can affect a pregnant individual. It can directly damage the trophoblast, the fetal tissues. It can immunologically damage the trophoblast and the decidual cells. It can have an anti-angiogenic effect and prevent the spiral artery remodeling and angiogenesis at the decidua. And there can also be formation of microthrombi and complement activation in these blood vessels with fibrin deposition and placental fibrosis. Now, how these obstetrical patients once diagnosed are managed. So we diagnose them with Rotterdam's criteria we saw in the earlier lectures. Now, if there is no prior clinical features suggestive of antiphospholipid antibody syndrome and they are carriers, we give them low dose aspirin 75 mg per day. If they are asymptomatic carriers with thrombotic risk and recurrent pregnancy loss with no prior systemic thrombosis, we can give them aspirin and prophylactic heparin. Unfractionated heparin can be given in 5000 international units subcutaneous twice a day or low molecular weight heparin 40 mg twice a day. And if the patient has previously systemic thrombosis, then patient should be given a full therapeutic dose of heparin throughout the pregnancy and continue 6 months postpartum. So what are the protocols for obstetrical APLA syndrome? So we have seen that the conventional treatment and for the regimens for primary APLA syndromes in an obstetrical patient include low dose aspirin, that is 75 mg per day, plus prophylactic dose of unfractionated heparin, that is 5000 international units subcutaneously twice a day, or low molecular weight heparin 1 mg per kg body weight subcutaneously per day. Now there is also something called as refractory APLA. So we have given these patients aspirin and heparin, but still they have aborted or developed preeclampsia. So this refractory APLA syndrome form 20 to 30% of the cases. So what we should do? So in a refractory obstetrical antiphospholipid antibody syndrome, we have to give them preconceptional low dose aspirin, and heparin is commenced much early in the first trimester. We do not wait for the ultrasound documentation of fetal cardiac activity to appear and then start on heparin. And they should also be given vitamin D in refractory obstetrical APLA syndrome. Now, when should we change from prophylactic to therapeutic dose? So when unfractionated heparin, the therapeutic dose is 10,000 international unit twice a day and low molecular weight heparin twice a day. So if there is a triple APLA positivity or if there is a previous systemic thrombosis, then we should do not give prophylactic dose. We should give them therapeutic doses of anticoagulants.